for it? Okay, all right, so my name is Becky Hamblin. I am now the therapist at Rogers Behavioral Health in Tampa. I started off in Tampa as a postdoctoral fellow with Dr. Eric Storch. A lot of you guys are probably familiar with Dr. Storch and the Rothman Center. So I came to work for him about 2.5, 3 years ago. So it's been a wonderful experience, and I've learned a lot from him. And I appreciate that I get a lot of these kinds of opportunities when he is in 4 places at once to come and talk to you guys. So thank you very, very, very much for having me. Thank you, Betty Ray, for asking me. I really appreciate it and am honored to be here. So what I was asked to talk about was common co-occurring problems with Tourette syndrome, which is good because I know a whole lot more about the common co-occurring problems than I do Tourette specifically. And that's because Tourette is maybe a little bit more infrequent than some of the other problems. But what people who have Tourette syndrome, as you guys know, 90% of the time they have some other kind of co-occurring problem. And sometimes the other problem might be even bigger and more problematic than Tourette. So really quickly, the most common by far is ADHD. Most people probably know what ADHD is, especially if you're sitting in this room. So I'm going to be kind of brief on what it is and talk more about how it relates to Tourette syndrome. All right, inattention, you guys know this. If you don't, we can come back to it. I'm gonna try to talk through for maybe 20 or 30 minutes, and then we can just kind of talk Q&A, like questions you might have. All right, and then hyperactivity and impulsivity. All right, so people who have ADHD, I want to talk about some of the other problems that they tend to have because so many people with Tourette syndrome do have ADHD. It's so common, people almost kind of say it like a joke, just like they do OCD. Oh, I'm so ADHD, oh, I'm so ADD, and just like any other kind of difference, it's not a joke, it's not funny, it's actually really very impairing. And it might not look as different to some people as Tourette syndrome because so many more people have ADHD, but it's really important to know it and to address it. Because we know that people who have kids who have ADHD grow up to have not just more problems in childhood, but continue to have more problems in adulthood as a result of ADHD. And I brought up this diagram because it's very pertinent to what we're talking through today. About half of people who have ADHD, less than half only have ADHD. For Tourette syndrome, it's actually 90% also have another problem. So only 10% of people with Tourette syndrome have only Tourette syndrome. But then along with ADHD comes this whole other slew of problems, from depression to anxiety disorders, conduct disorders, and then a significant portion who meet all of the above criteria. One of the reasons that it's thought that ADHD goes along with Tourette syndrome is very similar neural pathways in the brain. The motor cortex particularly and the frontal cortex are thought to be involved in both. So it's really not all that important to me anyway as a clinician, because whatever I treat is going to treat the brain too, but a lot of people like to ask, why do these things coincide? Maybe genetics, yes, some people have a genetic tendency for both. Maybe these neural pathways are both involved. All right, so treatments for ADHD related to Tourette syndrome. The gold standard of treatment for ADHD is stimulant medication. You guys have probably experienced the problem with stimulant medication with Tourette or any kind of tic disorder is it increases tics. In my experience, more often than not just tics, but it also can worsen OCD, can bring on OCD, can worsen anxiety, can bring on anxiety, can worsen depression, can bring on depression, and these are all the main problems that come along with Tourette Syndrome. So then what do you do if you have Tourette Syndrome and ADHD, as most people do? Most people with Tourette Syndrome do, anyway. There is another alternative. Most people don't know that there is any treatment for ADHD other than stimulant medication, but there are behavioral interventions, not to cure ADHD, but the stimulant medication doesn't cure it either. It's a temporary Band-Aid that alleviates some of the symptoms and causes other problems too. I'm not against medication for ADHD. When it coincides with Tourette's, though, it's a much more complicated picture. All right, so good things about stimulant medication. Oh, they didn't come up. Interesting. Did we go back one? Did that just? All right, no, that's okay. I know the good and the bad. So the good part about the stimulant medication is it works immediately. You have ADHD, wake up, take a pill, bam, it works. It's not like the SSRIs with depression where it takes a couple of weeks. It's immediate, and it tends to make all the adults around the person happy, or if it's an adult, tends to make people's bosses and others more happy. The bad news, as I said, again, all of the side effects, not just the physical side effects that everybody has, dry mouth, constipation, all those things, but worsening of Tourette's and OCD and anxiety and depression. All right, so contingency management, there are behavioral interventions, like I said, for ADHD. The good thing is all the side effects of contingency management are positive. When we do behavioral interventions, it decreases depression, decreases anxiety, no thought that it increases tics, no suggested evidence that it does that, strengthens family relationships, strengthens academics, strengthens all the comorbid problems that come along with ADHD. The bad part is it's more time intensive, possibly more initially, especially at first, might cost a little bit more money. You can get, off-brand generic stimulants for fairly cheap compared to going to a therapist and getting a whole spectrum of services set up, because that's what it takes. Behavioral interventions for ADHD are not just 1 hour a week therapy. This is a whole system of things you put in place at school, a whole system of things you put in place at home, individualizing things to meet the specific person or child's needs. And it takes a lot of effort.
Quick question about the behavior therapy stuff. Has anyone looked at the CBIT therapy that they're doing now? Does that cross to the ADHD at all? Like, can it help? Like, if a kid's doing just the CBIT, can that help with some of the ADHD symptoms, or are you sort of doing two different therapy strategies for that?
Tell me what CBIT stands for.
So this is the cognitive behavioral intervention therapy that's working at trying to, with a child with Tourette's, to sort of do an alternative to the tic, right?
Habit reversal training,
sort of how to understand maybe, so
Yeah,
that way you could
so-
probably go off all medication if you wanted, or try to.
Habit reversal training, there isn't any evidence to suggest that it also decreases ADHD symptoms. What I'm talking about, though, for ADHD is a whole slew of interventions designed specifically for ADHD. And I would say it definitely, treating all of the ADHD symptoms and setting up a practice for the child to learn how to control impulses definitely would help them also be able to learn to use the CBT for Tourette syndrome. And I'm going to come back to all those things. I know I just brushed over what the behavioral interventions are for ADHD, but I thought we'll come back and discuss things more in depth in a little bit. All right, next most common co-occurring problem with Tourette syndrome is, of course, obsessive compulsive disorder. And I thought I'd spend a little bit more time talking about OCD relative to the others, because we hear about ADHD all the time. We hear about depression, you see commercials about it, but people don't know as much about what OCD is, and it varies widely from person to person. OCD in one child looks very, very different from OCD in another child, and same with adults. So OCD is essentially obsessions and compulsions. Obsessions are not things like I really love cats and I talk about cats all the time. That's an obsession, but that's not what we're talking about with OCD. Or I love to play video games, my kid won't get off the video games, and does he have OCD? No, because he likes those things. Liking, he likes to talk about cats, he likes to play video games. It's different from somebody who has obsessive thoughts that are intrusive and unwanted. So obsessions can be a number of things. They can be images, pictures, even like short movie clip type things. Kids will describe it as kind of like a movie that plays in their head. It can be an urge or an impulse, similar to in Tourette Syndrome, except in Tourette Syndrome it's an involuntary, and in obsessive compulsive disorder there's more forewarning, I guess you'd say. And thoughts, obviously the most commonly known are thoughts like my mom might die so I'm gonna move these chairs in a certain way, or I just need these things to be lined up, so just right kind of feelings. And then the repetitive behavior is the compulsion. Anything that they do that follows the unwanted thought or image or impulse to relieve the anxiety, to relieve the urge or the feeling, or to prevent something bad from happening. All right, so I put this up here because everybody in the world can relate to OCD. Everybody thinks it's, like just being perfectionist or just being neat or just being afraid of germs. But it's actually, everybody has OCD. Everybody has some level of this. It's just an intrusive, like most people have it as an intrusive thought that they don't know where it comes from. Really common ones, I give the example when I drive across bridges, I'll sometimes have like an image flash or an impulse like to drive off the bridge. I don't want to kill myself. I never would want to drive off the bridge. The first time that happened when I was 18 and just driving across bridges for the first time scared me to death, freaked me out. Why in the world am I having this? Am I suicidal? I don't know. Another common one, when people use knives, they'll have a sudden thought or image of them turning around and stabbing a loved one. They don't want to do that, of course. I've had this one 800 million times. You're typing it, you're searching on something on Facebook and you think, oh my gosh, what if I accidentally post this instead of searching for something? Just kind of, it's a fast alarm type thought are really common. People having a random image or thought about them like kissing a supervisor or doing something else like wildly inappropriate, taking off all your clothes and running around the room. There's so many, I could talk for days about all the different kinds of ways that OCD can manifest, but it's some kind of usually perceived as nonsensical thought or fear or urge or picture that the person has, and then they do something to relieve it. And the something to relieve it All right, so this is a list of common obsessions. This is actually the Children's Yale Brown Obsessive Compulsive Scale. This is the measure that we use when you come in to my clinic and say, hey, we might have OCD. This is a starting point checklist, essentially, of do you have this obsession or that obsession. All right, so let me go back to the compulsions part. I thought must be that blank slide was the one that that I thought I had there. The compulsions can be either completely unrelated, like I think my mom is going to die in a plane crash, so I'm going to arrange these chairs in a certain way, to the obsession, or it can be very related. I had a thought and I'm worried that that might make me a bad person, so I go confess that to my mom or ask her, is that okay that I had that thought? Or it could be, this feels dirty, let me go wash my hands. So a lot of times, the ones that are completely unrelated, touching, tapping, rubbing, arranging things, repeated prayers, those things draw attention much quicker than the ones that are more related, which people, at least at first, tend to, parents tend to think well, this is just anxieties, just worries, just normal things, until it becomes to the point where they're confessing for a 45-minute car ride home from school every day and can't stop, or they break down in tears when you try to stop them. Oh no, you can go back to that one. All right, as I talk about everybody having OCD, just like I talk about everybody having anxiety, there's a reason for it. If we didn't have fears, we would all be dead. I mean, that's a joke that I start with everybody with psychoeducation. What do we call people who have no fear? Dead. Because if I would love to fly. I love Harry Potter, partly for the fact that they all fly around on broomsticks, and I think that would be totally awesome. If I went and started to step out of an airplane like this, thankfully I have an alarm inside my body that's going to tell me, no, don't do that, you're going to die. And I'm going to step back in. If I start to step out of the airplane, my whole body is going to feel really awful. My heart's going to beat, I'm going to sweat, all of those kind of things. It's going to be bad, and then what it's going to tell me to do is to get back away from that, get away from that. So we're evolutionarily or creationally or whatever, however you want to think about it, we are all predisposed to have fears and anxieties. And the same is true of obsessive thoughts. I kind of think maybe the reason I have that random thought sometimes when I'm driving across a bridge is because I space out when I'm driving. I'm thinking about lunch, I'm thinking about what I'm going to have for dinner, I'm thinking about that paper from 3 years ago. I don't know what I'm thinking about, but I'm not thinking about the road in front of me, and my brain has this flash of, hey, this could potentially be dangerous. Wake up and pay attention. And I pay attention. It's not a bad thing. If I go put my hand in a dumpster, I'm going to have a very uncomfortable feeling, and I'm going to want to go wash my hands. That's a healthy, adaptive thing. You all, everybody in the whole world who's healthy has some amount of obsessions and compulsions, and some of them are even a little nonsensical, and that's okay. All right, so if there were a tiger in this room, we would all freak out. We'd all have those same kind of physical sensations. Again, that's a good thing. We can skip through some of this. All right, so I did want to talk a little bit about anxiety and OCD and how to tell the difference between the anxiety and OCD that everybody has and when OCD and anxiety become a problem. Every child has fears, hopefully, and anxieties and worries, and you don't need to bring them into a clinic the first time they express those things, or you yourselves don't need to go into a clinic the first time you have some fears and worries. But when it gets to be a bigger problem, it's something that that's better addressed than not. Okay, so the good news is, just like we have some interventions for Tourette to make it more manageable in life, we have interventions for ADHD, not a cure for ADHD, but for OCD, anxiety, and depression. We have really good treatments that can pretty much knock those things out of the water for most people. And that's because, I think it's because we're all so prone to this that I think it's so much more relatable. I think it got a lot of early attention and study from psychologists. Honestly, if you know psychologists, a lot of them are really anxious. This is my theory. I really shouldn't say that. I forgot the videotape thing. But this is my theory. My theory is the reason that we're so good at treating anxiety, OCD, and depression is because they're so much more ubiquitous, and because really smart people tend to be really anxious, and who does the studying and the fixing of things is the really smart people. So that's my theory anyway. But basically we also have a really clean model for how OCD and anxiety work. And I'm lumping those two together. Not everybody with OCD experiences it as an anxiety phenomenon, but the models are so similar that it makes sense for me to just talk about them as the same thing. So basically you have a situation that sparks some anxious response. Person does something to escape or avoid. In anxiety disorders, it's literally escape or avoid, like me stepping back in the plane, which is not a disorder, that's just a good decision. And in OCD, it's doing whatever ritual it is. And avoidance, by the way, is counted as a ritual in OCD, just not going near it. If I'm afraid that I'm gonna stab my mom, if I'm near a knife, I'm just gonna not go near a knife. That seems pretty reasonable, except you're not gonna really stab your mom. So when you stay away from knives because you're afraid you're gonna stab your mom, you don't have the opportunity for the two parts of your brain, the one part that says, hey, that's never gonna happen, and the one part that says, but what if it might? What if it does? You don't have an opportunity for those two parts to sync up and to learn that you're not actually gonna stab your mom. And so you're basically rewarding your brain. When I step back in the plane from trying to step out, my body's gonna go say, I'm gonna experience this massive feeling of relief, and my heartbeat's gonna go back to normal and everything else, and that's gonna feel really good in that moment. Just like if somebody with OCD washes their hands, they're gonna experience this bit of relief. That does two things. One, it doesn't let you learn that the bad thing isn't gonna happen, but it also rewards your brain. It says, good job, brain. You're doing what we need to do to keep us alive and to keep us healthy. That must have been dangerous, because when we stayed away from it, we felt better. We didn't die. Keep doing what you're doing. And so the next time you're in that situation, the fear is gonna go up. Hey, remember, this is dangerous. I told you last time it's dangerous. When we stayed away from it, we felt good. So now I'm really gonna turn on the alarm, and the urge to do the compulsion or the avoidance is even stronger, and it builds and builds over time and becomes worse and worse. So basically, I mean, you guys know these physiological parts, like I was talking before, the cognitive parts, the images, thoughts, whatever those are, and then the behavior is, staying away from it. What separates anxiety and OCD from just anxiety and obsessions and compulsions that everybody has is that they start to impact your life more than other people of a similar age. All 21-year-olds worry about their future careers to some degree. If they're doing that that's pretty normal and healthy. You want to be able to worry about your future career because you want to be able to plan and think ahead. If you are 21 and you're worrying so much about your future career that you're not getting your homework done and you're not doing anything else and you're not going out with friends because you're so busy looking at career guides or whatever the case might be, then we've moved into problem areas. All right, so I'm gonna click through these, or he's gonna click through these for me really, really quickly. There are different categories of anxiety disorders. For your knowledge as parents, and even for me as a clinician, it's really not all that important where we draw the lines of distinction. I've never, ever, ever had anybody come in with just one anxiety area. Never had anybody with OCD who did not have some other kind of problem, and I've never had anybody who comes in with some clean, straightforward, this is my anxiety and there's no other overlapping areas. So there's generalized anxiety. That's people who worry, and everybody worries, but people with generalized anxiety find that they're worrying most of the day, every day. They find it excessive and uncontrollable. Social anxiety, the most common anxiety disorder, other than specific phobias, is social anxiety. And again, there's an adaptive reason for that. We are all made so that we want to fit in, we want to be part of the group, and we have alarms in us that tell us when we're not following the social rules or when we might be rejected. Because it's to our advantage to be able to fit in with the group and work collectively. Panic disorder, this is when people have out of the blue panic attacks, and they don't necessarily equate them with anything, or they might only have them in certain situations, but they don't know why. They're just all of a sudden panic attacks that happen over and over again. Separation anxiety overlaps really a lot with OCD. It's basically anxiety about being away from some kind of attachment figure. have a little girl right now who is afraid that if they're in the grocery store and her little brother and sister wander more than an arm's reach away, that they're gonna be kidnapped. So she's constantly checking and pulling them, and mom get them, but she also can't leave mom because she might be kidnapped. So she's, if little brother and sister wander too far away, she has an absolute panic attack. Sometimes, more commonly, separation anxiety shows up at 4 or 5 or 6 when kids are starting school and they don't want to leave mom and start to refuse school, things like that. Nightmares about something bad happening to parents, those kind of things. Specific phobia those are the easiest and most straightforward, but not necessarily the least debilitating. It's just being afraid of a very specific thing. Lightning, needles, thunderstorms, snakes, spiders, dogs. Yeah, this is the most common anxiety disorder. If I asked you guys all to raise your hand if you think you have one of these, would you be willing to do that? Raise your hand if you think you have a specific phobia. Okay, so that's like 100% of the room, and it's actually only maybe 20% of the, 20% still a lot, 20% of people, but that's because it needs to be really impairing. I once saw a lady who was afraid of snakes. She was afraid of snakes her whole life, and it was never a problem until she moved to the South and she liked gardening. And there are venomous snakes in the South, and they were, hi. Hi. Sorry. Don't be sorry. How? Well, he ran away. Okay, so it has to be interfering in some way. So I apologize for these blank slides. I have a Mac and I made this on a Mac, and it looks like maybe some of the slides didn't transfer over. Anxiety is very impairing. And these things, anxiety and OCD, they start early. They're very prevalent in the population. They persist, and they tend to be what we call pre-comorbid to other conditions. So they set the stage for other things like substance abuse and the later problems, depression especially. All right, so there are very good treatment options, like I said, for anxiety, OCD, and depression. I didn't make as many slides about depression, again, because I think you guys see enough Prozac commercials to know what that's like. But I did want to comment that in children and adolescents, depression looks a little bit different than it does in adults. In very young children, it will look like crankiness, oppositionality, overly sensitive, overly tearful, but the 1 minute and then the next back to playing. Young kids, like 10 and under, 12 and under, they don't tend to look like they are depressed. They just look like they're mean. Yeah. They're not actually mean. They're really cranky. They're in pain. And they won't, a lot of parents will say, well, he or she is not depressed. I see him running around, playing video games, doing all that. He's just doing that to annoy me. But that's just what it looks like in younger kids. Teenagers, it will look like, all teenagers sleep a lot. Teenagers, it will look like even more sleeping, again, cranky, irritable, snapping at people. All teenagers do those things, but when it becomes really out of character, that's when you think there's a problem. Withdrawing from people, isolating from friends, saying a lot of negative things about themselves, those kind of things. All right, so the treatment for anxiety and OCD is exposure therapy. I can talk more about this if you guys want, but I'm gonna kind of skip through so we can get to your questions. All right, thanks so much. All right, so I thought we'd spend, again, most of the time talking about what you guys want to talk about, so I thought I'd open it up to question and answers.
So what is your contingency management for ADHD? So where do you do that therapy, or can you just speak a little bit more about
Yeah, so, all right, so contingency management basically means that you're putting in very specific, structured, intentional, structured around behaviors that you want, and a lot of cues in the environment and things like that. You're basically setting up the environment to help the person with ADHD be more successful. And that involves a lot of rewards, a lot of visual cues, structures, schedules, and then for younger kids especially, like really mild removal of reinforcement for problematic behaviors. So behavioral interventions for kids with, I'm gonna just kind of talk about kids loosely, and then if we want to talk about ADHD in adults, because that is definitely a problem. So for kids, you want to have a multi-pronged approach. Addressing ADHD in the home is very important. Kids with ADHD have more fights and conflicts with their siblings, fights and conflicts with their parents. They have trouble doing chores, they have trouble doing homework, all of those kind of things. So contingency management at home is done through parent training. It's basically, we teach you, the parent, to be the therapist at home. We teach you how to specifically respond to and address the ADHD behaviors that are problematic. We set up a behavior plan that the child likes, and specifically for the child to address the specific behaviors. And I hate to be so broad as that, but it's like everything else, everybody's different. So we might have one child, for instance, the main problem is they're not doing their chores and they take 2 hours to get out of the house in the morning because they're looking for shoes, looking for lost things, distracted by the TV, distracted by that. A lot of kids with ADHD have really significant sleep problems, and a lot of kids with ADHD have a lot of trouble waking up in the morning. So first, yes, you come to somebody like me who knows how to set up those kind of behavior plans and what to do in the home. The second arm of it is setting up interventions at school. Kids with ADHD have a harder time than other people with organizing stuff. School is probably the most treacherous place for a kid with ADHD. Teachers, people who are drawn to the teaching field, and I love them, I have the utmost respect for them, they're not like me. I forgot this video. Well, I am like disorganized, messy. My brain doesn't work like that either. It is hard for me to put systems and structures in place. And I remember as a kid, I'd constantly be yelled at by my teachers, like, Rebecca, put that in your binder. Well, I got lost between like picking up the paper and getting to the binder. Somebody talked to me over there. It just wasn't an easy thing for me. And same for kids with ADHD. And a lot of teachers are very good at organization. They're drawn to this field because they like the structure and the routine, and they like the learning and those things. And so it's hard for them to sometimes relate to a kid for whom this is really difficult. Like, why can't you just put it in your binder? Why are you being so lazy? Well, they're not being lazy. They're actually a lot of times very energetic. And then there are other arms, depending on how bad the ADHD is and the age, there are other interventions as well. There are actually summer camp programs. They're full day, everyday summer camp programs that work on addressing everything. They have sports, so that they work on like good sportsmanship, and a lot of kids with ADHD and Tourette and other things have motor coordination problems, so they're working on building those motor skills so they can fit in better in PE classes and things like that. They have academic instruction, and they have parent training. And when I say parent training, we're not teaching you to be a parent, we're teaching you to be a therapist to your child with this particular set of needs. Does that answer your question?
Perfect.
Okay, yeah. So resources for ADHD, Rothman Center is a good place. They're gonna see kids with ADHD. If that's not a good resource for you, then come find me after. Yes.
Question. We've run into this before, I'm sure other parents have as well. When you get into behavioral interventions with kids with Tourette's and ADHD as a comorbid, what we always come across as a biggest stumbling block is when you try the inconsistencies of Tourette alone. seem to have the big wall comes up out of nowhere. So as you try to implement, or as we try to implement, let's rephrase that, an intervention plan, we always go outside the parameters of that original intervention plan so we can sort of kind of make it work. And it doesn't really, is there something that you've come across to make it really work? Because as example, it's going to be a bad example, but okay, Alex, if you do this 5 times well, then you're going to get this. So he gets up to number 4 and it hits the ground, falls apart. Well, now you got to start over again. Well, that therapy doesn't work. So now we go into, okay, well, if you can do it 5 times, and this is coming from school therapists as well, then we'll get it. What happens now in our world today with Alex at age 12 is that those 5 times can happen in 2 weeks. It doesn't really matter. So the parameters are really large, but is there any way to shrink that you've come across without, with using the pitfalls of Tourette Syndrome?
Yeah, absolutely.
What do you find that?
Yeah, so good rules for behavior interventions, and this is not just like fixing bad behavior, this is fixing anything. This is setting up a structure for any kind of problem that you're having, adults as well as kids. So good rules, it's gotta be extremely individualized. That's why I speak so broadly when I say these things, because it's a good behavior plan is built specifically to the child, to the family, to the school setting, to their needs, targeting very specific behaviors with very specific reinforcers that work for that child. And then second really big rule, other than being individualized, it has to be attainable. They have to be successful. The third big rule is it's evolving. A behavior plan, you put a behavior plan in front of a child with ADHD and leave it there and it'll work for 3 days and then it's done. Because kids with ADHD need they need things to be new, they need things to be fresh, they need to feel successful. What happens if you set it up too big, too broad, if it's taking 2 weeks to complete a goal, you're sunk from the beginning. If this is a 2-week goal, unless you're reinforcing it by the hour and by the day also,
right,
you're just done, because they can't do that. That's part of the definition of ADHD, is they have a really hard time planning into the future and controlling their behavior into the future. So I would say yes, you absolutely need to modify the behavior plan to be more specific to his needs and meet him where he is right now. Behavior plans should start off very, very attainable. What happens when there's these problems, these kids are also very depressed. And they're depressed because everyone in the world is yelling at them. Why can't you sit still? Why can't you be quiet? Why are you making that noise? Why are you doing this? And they're anxious because they desperately want to please everyone in the world, and they're feeling more and more hopeless about how to do it. So for a behavior plan, you have to take those things into consideration. This is not just them being bad. This is a more significant problem than that. You have to start it off so that they are successful. You have to be big and over the top with the praise, with the rewards, with all of those things, and then you start spacing out the goals to bigger and bigger and bigger, and you start making things harder, of course, as they go along, but you're still rewarding a lot as they're meeting those new challenges, and they're growing and more able to control their own impulses and behaviors. Does that help?
It does. That seems to be what we're finally getting across now, eventually. But it just took so long to get there. And every time we run into a new situation or a new behavioral therapist at the school, then it's, we turn into this let's reinvent the wheel. And you know what I mean? So if it's working, then it gets changed, and we go back and forth all the time with behavior intervention plans. So I was just wondering if there was something in specifics. I mean, we know what works generally, and what you said seems to work. That's kind of where
but you have to be constantly refreshing it, renewing it, like changing the goals, changing things, like keep them kind of on their toes, but in a good way. Keep it fun and exciting and doable, and so that they feel like they're successful.
We've noticed like more functional behavioral analysis or it keeps people's minds going like, oh, well, he did change over 6 months.
Mhm, yeah.
But yes, it is helping.
Yeah. One downfall I would say about behavior analysts and behavior specialists and those is that, yeah, everybody kind of takes their own view of things, and so yes, when you move from one to the other, it can feel very different. They should be using the same underlying theories and principles, but yeah, it can be different. I will say this is for all people and all differences and disorders. Eric Storch says you don't marry the first person you date. If you've got a therapist and it's not working, find somebody else. That's pure and simple. If it's not helping you, if you don't connect, there's nothing wrong with that. It's, you know, it might not be you, it might not be them, it's just for whatever reason that connection isn't there. Yeah.
Two things with regards to setting up reward systems. I have a hard time picking what that's going to be. I try to look to him right now, it's milkshakes. So, okay, fine, we're gonna do milkshakes. Do you just suggest that you look to the child to kind of set that tone? And then second, is there a negative component to, it almost feels like a bribery system, right? So, does that make them feel kind of like a hamster on a wheel a little bit in a way, where it's like, you must perform in order to get blah? I know that they've done studies about like what they were doing with the reading in the schools, that when they incentivized the children to do the reading over the course of like 10 years, they found that whatever that reading program is, children were less inclined to read, that they were reading more often and better out of pleasure. So what are the pitfalls as far as, you know, making this personally rewarding to them instead of just being a carrot on a stick?
All right, really, really good questions, and multi-layered questions.
Sorry.
So no, that's okay, they're really good. The first question was rewards, okay. So choosing rewards for kids with ADHD, consumable rewards, meaning like, you don't say, we're gonna go buy you that electric scooter that you want.
Right.
If that's really what they want, then make it money, like that they can earn and save up for it. So consumable, milkshake is consumable, screen time is consumable, things that like have to be repeated. The other thing, for kids with ADHD, have a menu of rewards that they can pick. If you want a milkshake one day, but the next day you're not so inclined for a milkshake because you had a bad day, you're not
Yes.
feeling well, then the milkshake is just irrelevant, and then you know you kind of lost the system. Okay, and you bring up a very good point in research about intrinsic reinforcement versus external reinforcement. It's true, kids who enjoy doing things just for the sake of doing it, when you introduce an incentive program for, say, kids who like to do puzzles, then you say, hey, do this puzzle, I'll give you $1, they lose the intrinsic motivation actually over time. It's not a thing that you just do for all kids for everything. Because, you know, if you like to sing, go sing. If they like to sing, they're gonna be doing a lot of singing. My guess though is that homework isn't so intrinsically motivating, and that he's not doing a whole lot of homework or chores or those kind of things. That doesn't mean though that the reverse doesn't work, that incentivizing from the outside some of these behaviors doesn't lead to intrinsic reinforcement later. It does, it absolutely can. Yeah, once they start to feel successful and get some ground, it absolutely can be more intrinsically motivating. But part of your job as the parent therapist is to draw those connections for them. Wow, look at what you did. Doesn't it feel so good now when we're in the store and you can multiply and help me count the change for the cashier? Whoa, look how clean your room looks. Doesn't it feel nice to have everything tidy? And look, you put all your stuff away last night and it's made it so much easier to get ready this morning. That's great. So you're building in some of that extra intrinsic reinforcement with the help of the extrinsic. Does that make sense?
Yes.
Yeah, so absolutely, don't incentivize everything. If your kid likes to read, don't start rewarding them for reading. The reading is rewarding in and of itself. What I would say about the bribery system, Yes, to the extent that I am currently being bribed to be here, or that I get bribed to go to work every day. You know, yeah, you get paid for what you do. Every single behavior on earth has some kind of, like, everything we do has some kind of reinforcer, has some kind of reward. If reading is fun in and of itself, then it's self-stimulation, you know, it's this pleasurable thing in and of itself, and that's great. I love what I do clinically, I love what I do with research, I hate paperwork. And the only reason I do paperwork is because I'm gonna get fired if I don't. If it were up to me, screw that, I'd be home, and probably all of you guys, same thing. I only do paperwork because I get paid to do my paperwork, and I get fired if I don't. I do my paperwork because it means I get to keep seeing kids and keep getting to do the research and doing the other things that I want to do. That is part of life. I can't go home and just watch TV all night because I want to. I have to earn it first. I have to go to my job and earn the money to pay for the Netflix, to pay for those things. I have to pack my lunch for the next day and do the laundry and do all those things before I can sit down and watch TV. There's nothing in the world wrong with setting up the contingencies at home so that your child has to put away his backpack and have a snack before he watches TV. And I'm talking about little kids here, but I mean, same for teenagers. I mean, these things are relevant to absolutely everybody of all ages, adults as well. So yeah, that's kind of what I say on those. Thank you. Oh, okay.
John, real quick, can I interrupt for just 1 minute?
Yeah.
Because I got somebody I wanted to introduce who has to get along to another engagement and stuff. And some of you guys know this person and other people who are newer and never met him. And this is Ross Preville, and I just want to introduce you guys because Ross is the person who founded this camp 14 years ago, before me. So for those of you that have come for a long time, or those of you that are just, you know, relatively new but have had good experiences here, you know, you kind of have Ross to thank for that, for putting this event on the map. So
it's great to stop back by and see so many people still coming here. I put something on Facebook and said it's still going strong, which is great, because this was our favorite thing that we did, you know, 14, 15 years ago. You know, we started a golf tournament in Tampa to pay for this, and then this became really our favorite event. But there are a lot of people who are involved in doing that, and you know, Chris, you know, Chris obviously has been doing it longer than I did, and thank you for your leadership on that. But it's great to come by here and see just how many families are still coming to this, and watch the kids out there having a great time. So I'm glad you're here. I'm glad you're enjoying it, and it's nice to stop back by.
yeah, Ross and I remember these 18 and 20-year-olds when they were 8, 9, 10 years old. So
Yeah, they're coming up to me now, and it's like, I remember you, and I'm like, who are you?
yeah, we probably look a little the same. They look a lot different. So.
Yeah.
But
Anyway, thank you, Chris.
excellent. Thanks.
Thank you for your
Thank you.
And I'll let you back at Becky for as long as she's willing to entertain your questions.
All right. Yeah, go ahead.
In the beginning, you had talked a lot about stimulant treatment with ADHD. What are your thoughts or experiences about treating it with non-stimulant medication?
Highly individual, highly individual, yeah. Guanfacine, Intunib, the research on that for children with combined type ADHD shows that it helps, especially with the hyperactivity and impulsivity, not so much with the inattention. And the inattention can be just as impairing as the hyperactivity and impulsivity. But we also, there's a lot of research that suggests that different medications work even for different kind of subtypes or classes, like kids with Tourette's comorbid with ADHD might respond slightly differently than a kid with inattentive type ADHD only, for instance. So it's very individualized, but there are also other adjunctive treatments too. Clonidine, I believe, is the one that can be added to a stimulant to kind of, basically, you can add a medication to help reduce the side effects of the other medication. I say whatever works for the individual child, but just know that there are other interventions as well. And from my perspective, you should never, ever, ever treat ADHD only with stimulant medication, because then as soon as it's 8 o'clock at night, then nobody's got the tools to to deal with it. It's just, you know, the stimulant wears off and you're gone, and you haven't addressed the oppositional behavior, the depression, the anxiety, the organizational skills. You haven't addressed any of those other things that go along with ADHD. Yes.
So being a mom who is a teacher, kind of a planner, and my daughter is more of the ADHD executive dysfunction. My first question is, can planning and planning and organization, can that be a taught skill? Or do I just give up the game?
No, don't give up the game, but don't get frustrated with it. It's never gonna be as innate for her as it is for you. Realistically, no, we don't have a cure for ADHD. I wish that I could just become innately gifted at organization and planning, and it ain't gonna happen. But that doesn't mean that there aren't many things that can be done to help along the way, to help her be much better at it than she would be otherwise, and to learn the skills to put in place for herself. This is how I think of all differences. Everybody on the planet has things that come very easy to them, like their brain just seems to kind of know what to do. It's just, it's effortless. And everybody on the planet has things that it seems like for everybody else it's so easy and effortless, and for them it's just not. You know, there are certain things that are just really easy for me, and I don't I couldn't really completely relate to why it's hard for somebody else, other than I know that there are things that are hard for me that I have to put extra effort in. You just have to be able to accept your own strengths and weaknesses and your child's strengths and weaknesses, and know how to help them through, help them buffer the weaknesses and use some strategies and put some structures in place, and celebrate the strengths at the same time.
So with all that being said, how does executive dysfunction correlate with ADHD? Does it overlap? Does it?
Yeah, so executive dysfunction, some would say it's the same thing, that ADHD is a type of executive dysfunction. Executive function is a little bit more broad. There are memory and all kinds of things that go in it, and then it kind of depends on what theory of ADHD you want to look at. But Russell Barkley, who's probably the biggest name in ADHD, says that it's a kind of executive function dysfunction, and that short-term memory impairment is at the root. I don't agree on the short-term memory piece, but yeah, certainly.
Thank you.
Yes.
I'm trying to remember because it's so hard to concentrate. I thought you hit on something a while back about the variety of incentives or whatever, because I know our son is now 18. When he was younger, we'd come to this and you'd be thinking, trying to find the magic bullet, and it seems like it kept changing with him. Like he used to joke, like you would have a teacher and they'd talk about, he does this behavior, it's all very logical, he does this behavior, we'll try this incentive, and therefore we'll see it. And it would work for a little while, and then it would change, and it was like, he was like the Borg on Star Trek, that he was always adapting to whatever the scheme was,
Yeah.
and then you had to try something new. So I've always found the good thing about coming here is you get a lot of, everybody's convinced that year that they found the magic bullet. You get a lot of good ideas, and it's worth trying them. Because often I come back the next year, and it turns out it stopped working about halfway through the year, but because you need all they're really challenging, because most of the kids are like a furball of all these different conditions.
Yeah, and it's, they're also kids. They're growing and changing and developing, and I might want a milkshake one day and not the next day too. All good behavior plans should be constantly evolving. They should be like updated weekly, changing the incentives, changing the goals, what's the marker for the incentive. And for all kids, but especially kids with ADHD, you gotta keep things moving and keep things fresh for them and keep them feeling successful.
And then we found sometimes they'll make progress in one thing, and then they'll backslide because somehow they're working on another aspect.
Yeah.
So it's not always.
No, it's not linear. None of us are linear either. Yeah. Go ahead.
I just wanted to offer a glimmer of hope. Around Katie's age, I was literally writing in white chalk marker on Vanessa's mirror, wake up, eat, brush your teeth, get dressed, get your books, go to school, and now she's waking herself up and doing her homeschool on her own. So there is hope.
That is so, thank you, sorry.
Yeah, I did not mean it in any way to imply that there is not hope. It absolutely gets better. Will it ever be as innate as it is for you? No.
She's never gonna
but-
make her own dry erase board for herself.
Yeah, exactly,
Yeah,
exactly.
yeah, no,
But,
I was-
well,
Or
no,
she'll do it,
and that's not.
And then she will forget about it tomorrow.
Yeah.
Right,
Or-
she'll get excited about it.
When she goes to college, she may say, hey, I did this before and it worked, and yes, then I can implement this. It might be that the other kids in college don't need a white, I have a dry erase board for stuff that I'm supposed to do. You know, it helps.
I
And
have
so,
four in my house.
yeah. But absolutely, so basically the research that's been done for ADHD and these behavioral interventions has been extremely short term. The one big, huge study that everybody talks about, they looked at stimulant medication alone, stimulant medication plus behavior interventions and behavior interventions alone. But here's, and then like a control group. Here's the thing, the control group was mostly taking medications. They were just, you know, as whatever, and the medication group was a much more controlled medication group. And what they found was that the stimulant medication and the combined behavioral and stimulant medication was just as good for ADHD as the stimulant alone. But again, all of the other things that come along with ADHD were better when they did the behavioral interventions. But here's the thing, they withdrew the behavioral interventions a month before they did the outcomes, but the kids who were on the medication were still taking the medications. So it was an unlevel playing field, a very good study, very big, took lots of money, and studies are hard, no research is perfect, but it's always something I remember, hey, you did 6 weeks of behavior therapy, but then those were withdrawn 4 weeks before you did the outcomes, and still the behavior interventions still showed some reduction in ADHD symptoms. So yes, there's absolutely hope, and what I've seen more anecdotally, you do the interventions and you do them enough, and yes, you absolutely see progress. And in fact, there's even some evidence that if you intervene early enough with ADHD, you can potentially reduce like the risk that they actually have ADHD later. With preschoolers, doing the behavioral interventions with preschoolers there's some initial evidence that it can prevent ADHD for some kids. So yeah, please don't take that as not a hope. It's just a lot of work. You have to do a lot of work and be consistent and be patient with it. Yeah. Go ahead.
Well, this is kind of a two-part question. I have a younger one that is very unorganized. Is there any best practices to help her? Like, cause her organization, obviously we might, two different minds. Everything I've found is like one track. You label everything, you do this, you do that. She doesn't work that way. Is there like several best practices that you can try out other than that? Because that clearly is not working for her. And then also to transitioning from like one activity to the next. Like, is there a best practice? Like, you give them 5 minutes. Does that make sense? Like,
Yeah.
I know it's individual, but like.
So incredibly individualized, I'm gonna have a hard time answering that. There are several go-tos that I would have several thoughts I would have, that I would kind of parse out with knowing the child and the family. As far as transitions, those are easier than organizational tools. Transitions is, basically keeping the same thing, like make it predictable. Timers are extremely helpful for people with ADHD, even adults with ADHD. That's part of the executive dysfunction is having a lot of difficulty keeping track of time or having the same sense of time as other people. So having a big visual timer. Smartwatches, really, really best invention ever as far as I'm concerned. You can set up the calendar to alert them at like every hour of the day of what you're supposed to be doing as an adult or as a kid. So those are some good things to help with transitions. And you can set it, of course, your calendar to alert you 5 minutes before or an hour before. Definitely don't try to set transitions up so that you're not transitioning from like the most preferred activity in the world to a very undesirable activity. If you're trying to move from video games, which are very, very stimulating for people with ADHD, to doing the dishes, you're gonna have a lot more trouble than if you move from doing the dishes to video games.
Right, well, and we just have trouble transitioning, period, at
Yeah.
our house.
Yeah.
So, yeah, and they have a tendency to not want to transition at all. Like, they need like,
Stuck on one thing, I'm doing this.
yeah,
now.
yeah, like very
Rigid.
obsessive about that one thing. So that's what we're having issue with at our house, so.
Yeah. Again, like warnings, timers, like kind of setting it up, being predictable from day to day. Yeah, trying to have them set up from the beginning that they have enough time to complete that activity. Some people like really have this need to follow through to completion, even if it's something they don't want to do. So yeah, as far as organizational systems, I think that's just kind of individual for everybody on earth. Like, try to get her to like sit down with you and like walk through, like actively walk through, okay, so when you come in and put your things down, what's going through your mind, where are you putting this, what makes sense to you? When you're reaching for your shoes, where are you more likely to reach them? So I think, yeah, like actively, physically walking through it step by step and trying to get her to recount what she does and how she's thinking can help you.
Yeah, I've tried that. I don't get a lot out of her, so that's why, like, it's making me frustrated.
How old is she?
She's 10.
Okay, yeah.
So I like her, like, I've literally gone through her backpack. I spent one night, like an hour going through her backpack, like crinkled papers, things like, I have never seen this, like, you should have done it a week ago, like, clearly I don't think like she does, and I get that, but then like even her bedroom, and I'm like, why do you want to put it there? Like, you know, it doesn't bother her.
Yeah.
Maybe that's part of my problem, is it doesn't bother her and it bothers me.
It probably bothers her that it bothers you. Like, yeah.
Can I throw something on that? So I have the same exact problem, and I've always looked at it as my way of thinking, like, why are you putting that there? I'm a very logical person. Like, I'm gonna put your lamp next to your bed.
Right.
So you can reach out of bed and turn on the lamp. Where she wants it over here because she doesn't want the cat, you know, some emotional tie to it. So
Right.
Katie works more on emotional, like, well, that's just what I wanna do.
Right.
And it's my room, so I'm gonna do it however I want.
Right.
And I'm like, but it's not logical. It doesn't make any sense to put it there.
Right.
And so you gotta, and what Katie's therapist told us is let her do it. Let her, because we have a confidence issue with her. So the confidence level, let her do it and give her some insight, like, okay, we're gonna do a checkoff board, but you tell me what you want on the checkoff board. What is it that you're struggling with to put on this checkoff board, and give her that kind of insight to what you do to
Yeah,
organize.
I mean, I've even tried that, like, the boards don't work for us. I'm losing my mind on that. And yeah, the things where her things are in her bedroom, but then she has a tendency to lose them, is the problem, is I can't find them. Well, then she expects me to assist in finding them, you know, and then.
If I can,
My husband's got the same thing, so I'm the finder of all things lost.
it's the same in our household, and I have very strong OCD myself, which, you know, seems to be prevailing in our son's, comorbid disorder, and so I am having a mediator, my husband, so sometimes he needs to step in between the two of us, and he says, just let him do it. And I many times have to grind my teeth, and it's like, okay, Alex, if you like it, all right, and I walk away, and I have to get over my own obsession by not letting him do something, like, for example, you and mentioning the lamp, but to him it makes perfect sense.
Right.
And I have to reflect on my own obsessions, why this makes sense, and I score somebody, no, don't. So it's difficult, and I think that some of our own traits are reflecting on our children. Yeah, so.
I just find it difficult that, you know, if you put it in your closet, or,
Right.
like, I shouldn't have to find it if you.
But it does get better. It seems, I was just mentioning that with maturity, now he's 12, things got much better because he realizes what certain things mean to him, and they have value to him now, all of a sudden more than before. And he understands that he needs to keep an eye on certain things himself. So it comes with that, I think, also.
Okay.
That gets better with age, we noticed.
So I just need to let it go.
I would. I mean, in certain aspects, when it's not life and death situations, I tend to, yeah.
Maybe,
Okay,
maybe,
thank you.
maybe.
I mean, I don't know if you agree with us.
We
but-
have a lunch
Let it
bell.
go, yeah.
Well, no, what-
The
what-
adults don't eat till 12:30.
What I think is, I think
If you want to
logic
eat with your kid, you can
comes
join
with
them now,
maturity.
but if you're
Yeah.
okay
So,
waiting.
the older, the more logical their thinking is gonna be.
Mhm.
Logic is subjective too. I mean, to her it's very rational, to you, there's another rational, but, you know,
Right,
like,
right.
just because it's not rational to you doesn't mean it's
Right,
not
right,
rational.
right.
If she's, yeah. I do have to go, I have another engagement,
Oh, I think
this
we can take it.
afternoon. Yeah, you guys are doing awesome. I am, of course, not here to sell services or anything, but, you know, like I say, if you are, you know, you don't marry the first person you date, so if you do need.
Really? Are you sure? Because this is the first guy I dated.
Really?
And we've been married 18 years.
That's awesome. That's really cool.
We don't fit in that category.
That's unusual.
We're getting divorced tomorrow.
Yeah, don't do that, please. I don't know what I'm talking about. Don't
You know,
do
they
that.
say the exceptions prove the rule.
Yeah. Okay, so I do need to go, but I have some resources here for anybody who wants them. If you're already hooked up with great services, perfect. If you know anybody who'd use more intensive services, Rogers, you know, if things you're doing aren't working, then there are intensive outpatient programs and full-day programs and those kind of things. And I say there's always hope. At Rogers, we have lots of people who have not responded to OCD treatments or anxiety treatments or depression treatments elsewhere, but because it's a more intensive approach, we find most of the time they get better. So if anybody is interested in more intensive services or referrals to anywhere, I'd be happy to provide you those. So I have some Rogers brochures up here, and I have Dr. Storch's business card. Unfortunately, I don't have one of my own because I just got promoted, but yeah, thanks. So you guys are welcome to reach out to me. Even if you don't want intensive services, you just want the name of an outpatient provider, I can try to help you guys with that. Or if you have more questions that I didn't have time to answer today, I'm happy to talk about those too. So anybody want a business card or brochure? All right.
Thank you so much, Dr. Hamlin.